Mic check, mic check. 1, 2, mic check. Checking Dr. Ferrer's mic. 1, 2, 3. Mic check, mic. 1, 2, 3. Mic check, mic check.
Good afternoon and welcome to today's COVID-19 media briefing. Today I'll share our current COVID status, talk about some of the new circulating variants and what we're seeing in LA County, and take a minute to discuss the CDC's new vaccine guidance and available LA County resources. Take the next slide. I always like to begin with the trend lines. This gives us an overview of where we are compared to other points during the pandemic. That green trend line shows the 7-day average of daily cases by episode date, and it's measured using that vertical axis on the left. As of April 14th, you can see we're continuing to see some small decreases in cases. We're averaging about 303 cases per day. We were at 355 cases a week ago. As a reminder, this line captures large shifts in transmission, but it's not really considered a true count of cases due to the large amount of at-home testing that's not reported. That orange trend line shows the 7-day average number of hospital admissions. This past week, there was an average of 51 admissions per day. That's slightly higher than the average of 48 admissions, yet overall we consider this stable. While relieved that the number of average hospital admissions has been under 60 for the past month, a year ago, our average hospital admissions were about half of what they are now. While many different factors play into this, it's important that we all remember that our therapeutics and the bivalent booster are two tools that we can use to help reduce severe illness, and they're widely available in LA County. The blue line on this slide shows the 7-day average number of daily deaths. It's measured by the axis on the right. This week, we reported 44 new deaths. Compared to other points in the pandemic, we are seeing much lower numbers of people dying. However, these deaths are not insignificant, and COVID continues to be one of the leading causes of death in LA County and across the country. To those people who have lost a loved one to COVID-19, I extend my deepest sympathies and wishes for peace and healing. The next slide. While the trend lines for cases is an undercount, since it doesn't capture those home test results, Wastewater provides us with a more accurate information about the transmission levels in our communities. Wastewater concentration measurements of SARS-CoV-2 virus track levels in wastewater that aren't dependent on cases reported or captured through testing. On this slide, we have the SARS-CoV-2 wastewater concentrations from September of 2022 through April 8th of this year. Just a reminder, there's a little bit of a lag here because it takes us a few weeks to analyze and report on these water samples. The wastewater sewer coronavirus alert network data, that's what you're seeing on that main graph, includes samples from the Joint Water Pollution Control Plant, Hyperion, and the Lancaster sewer sheds. The blue line's that weighted average of viral concentrations across the 3 wastewater treatment plants, weighted by the population served by each plant. If you look at this main graph, you can see clearly that the winter peak was that week of December 4th, and there's been a clear downward trend in community transmission since then. Reported this week, the concentration level is slightly over 14% of the winter peak. This indicates that there's low concern for rapid spread of the virus. This level, as you can see, has been consistent over the 3 most recently reported weeks. The bottom graph in the corner, that green line, shows the wastewater concentrations from the Tapia sewer shed in Las Virgenes. For this sewer shed, we're seeing the same pattern, with concentrations substantially lower than the winter peak and generally stable over the past month. Next slide. Using the CDC's community levels framework, which looks at the case rate and 2 different hospitalization metrics, this week LA County remains in the low community level for the 14th week in a row, with a reported case rate of 30 new cases per 100,000 people, the same as the week before. CDC has not yet posted the updated hospitalization metrics today, but as of yesterday's data, the number of new COVID-19 admissions per 100,000 people was 3.5, pretty similar to last week, it was 3.3. For the second hospital metric, that's the percentage of staffed inpatient beds occupied by COVID-19 patients, LA County was at 1.9% yesterday, again stable from last week's value of 2%. I'll take the next slide. Tracking new strains and variants allows us to know early if there are new strains or lineage in LA County that's gaining dominance. On this graph, you can see the variance as a percentage of all the specimens we sequenced in LA County as of March 25th. Again, we have about a 3-week lag here due to the time it takes to sequence these specimens. XBB.1.5, that's that large orange kind of colored section, accounts for about 71% of sequenced specimens in LA County, and you can see it's our dominant strain here and nationally. However, you can also see that we saw a significant decrease from last week. Primarily, it reflects that increase in BQ.1.1, also an Omicron strain, that's represented by the purple section of the graph. BQ.1.1 was previously dominant in LA County during the winter surge, and this week it accounts for over 16% of sequenced specimens. You can notice on the chart it's about 3 times higher than it was in the prior recent weeks. But we looked into this and we learned that 70% of these BQ.1.1 cases came from 2 large outbreaks. So this likely means that the proportion shown here is higher than it is in the general community. Obviously, we'll watch next week, but we expect it will go back down. We're tracking the new XB.1.16 strain. You may have heard it's sometimes called Arcturus. This is the bright blue section at the very top of the bar, newly added to this graph. As a reminder, we do add these new strains to our graph when the CDC adds strains to their variant tracker dashboard. Based on our most recent data, which is again delayed a few weeks, the new strain accounts for about 1.3% of sequenced specimens in LA County. CDC Nowcast does use some models to estimate more recent proportions of variants. If you look at that Nowcast data, it predicts that XBB.1.616 accounts for about 7% of cases nationwide and nearly 10% of cases in Region 9, and Region 9 includes California. Most of the information we know about XBB.1.16 has come out of India, where we're currently seeing the most cases. Observationally, it's also being reported that this strain is infecting young children more, and that conjunctivitis, commonly known as pink eye, may be more common with XBB.1.16. Previously, conjunctivitis has been reported in about 1 to 3% of COVID-19 cases, so it's rare but not unheard of. Conjunctivitis can be painful and itchy, it's highly contagious, and if it's left untreated, it can cause some damage to the cornea. Ultimately, it's probably too early for us to say definitively if XBB.1.16 is associated with more conjunctivitis in children than with other strains. And it should not be a symptom that people rely on to define if they have COVID. It does remain important to test for COVID-19 to confirm this diagnosis. It's also important for those people who do have conjunctivitis or are caring for children with conjunctivitis to seek medical care. We'll be monitoring this, obviously, as we move forward. You'll also see a couple of other additions to this graph. You can see XBB.1.5.1 and XBB.1.9.1. Both of these are derivatives of Omicron, and they're still circulating at low levels nationally. XBB.1.5.1 accounts for 2.4% of what's seen nationally, and XBB.1.9.1 is about 6.5%. In LA County, you can see that XBB.1.5.1, it's the salmon-colored bar just above the orange section. It's accounting for less than 1% of what we've sequenced. According to the CDC Nowcast, it accounts for just over 1% of COVID-19 cases in Region 9, which again, that includes California. So pretty similar there. XBB.1.9.1, light brown color, just above the salmon-colored bar. It accounts for about 1.3% of what we're seeing. This is less than what CDC is estimating. They're thinking that XBB.1.9.1 accounts for 4.7% in Region 9. We're also tracking XBB.1.9.2. It accounted for 1.3% of sequenced specimens. CDC predicts it's about 2% of cases in Region 9. And the last of the strains we're newly tracking is something called FD.2, also a descendant of Omicron, XBB. That's in the dark red bar near the top. It also less than 1% of what we're seeing in LA County. CDC predicts that it currently accounts for nearly 6% of the cases in our region. These are a lot of new strains with a lot of letters and numbers. However, I think there are a few takeaways. Based on our local data and according to the CDC Nowcast, we're not seeing any large shifts or signals that new strains have begun outcompeting other strains. Although based on past history, we can anticipate the possibility that one of the newly circulating strains can become dominant. Based on past experience, as new strains become dominant, there's an increased potential for infection or severe illness and possibly new symptoms. Because of this, it's important that we do monitor our local conditions while we look at the data from other parts of the world and our country. The good news is that because all of these new strains are descendants of the Omicron variant, our vaccines and our therapeutics are likely to remain highly protective and able to ward off severe illness. Next slide. Studies and clinical data provide mounting evidence on the effectiveness of the bivalent booster at reducing the risk of symptomatic infection and severe illness, and our local data correlates well with the research findings. On this slide, you can see hospitalization and death rates over the past 90 days for LA County residents 65 and older. This is the age group that's most affected now by COVID-19. The graphs show that those who are unvaccinated compared to those who are vaccinated without the bivalent booster and those who are vaccinated with the bivalent booster. This data helps us understand if there are differences in hospitalization and death rates that are associated with vaccine coverage. The yellow graph shows hospitalization rates per 100,000 people, and the blue graph shows death rates per 100,000 people. Hospitalization rates for the 90-day period that ended April 3rd were nearly 5 times higher for people in this age group, 65 plus, who were unvaccinated compared to people who were vaccinated without the bivalent booster. For those who were vaccinated without the bivalent booster, their hospitalization rates, as you can see, were nearly double those when compared to people who had additionally received the bivalent booster. Overall, people who were unvaccinated were nearly 8 times more likely to be hospitalized compared to people who had the bivalent booster. It's sobering to look at these same comparisons for death rates for the 90-day period that ended March 27th. Among residents ages 65 and older, unvaccinated individuals had death rates that were nearly 6 times greater than people who were vaccinated without the bivalent booster. And for people who were vaccinated without the bivalent booster, their rate of death was twice as high as people who had received the bivalent booster. Unvaccinated individuals were nearly 12 times more likely to die than those who had received the bivalent booster. While vaccines are not a guarantee against severe illness and death, this data illustrates the very real protection offered by the bivalent booster, even against the newer variants that are circulating now. People often mistakenly think that they don't need updated protection because they have previously had a COVID-19 infection, or they don't even realize that they're eligible for the bivalent booster. This data helps us understand the significance of the bivalent booster, especially for people 65 and older. Next slide. This week, the FDA and the CDC approved changes to the COVID-19 vaccine schedules, including changes to the emergency use authorizations for the bivalent vaccines, meant to simplify the vaccine schedule. The decision was based on safety and effectiveness data tied to the original approvals and observational studies around vaccine effectiveness. These changes go into effect here in LA County today. The first significant change is that authorization for the Pfizer and Moderna monovalent COVID-19 vaccines has been rescinded, meaning that these vaccines are no longer available. As a reminder, the monovalent vaccine was formulated for the original strain of COVID-19, and since then we've seen many new variants. The bivalent booster is formulated based on the original strain and Omicron strains, providing a wider scope of protection. There are also a set of changes in the dosing recommendations, depending on whether you're unvaccinated or you've already completed a primary series. For individuals who are not yet vaccinated against COVID-19 and their ages are 6 and older, the recommended vaccine protection now is just one single dose of the bivalent booster. Previously, it was a primary series, 2 monovalent doses usually, and a booster. For children ages 6 months to 4 years old who are not yet vaccinated, the recommended protections are either 2 doses of the Moderna bivalent or 3 doses of the Pfizer bivalent vaccine. These are formulated a little differently, and so the dosing is done differently to maximize effectiveness. For children who are age 5, they're like the gap in there, and they're not yet vaccinated, they can do 2 doses of the Moderna bivalent or 1 dose of the Pfizer bivalent. Again, these vaccine doses are determined to work best with a child's immune system at different ages. For the millions of people who received their COVID-19 primary series vaccine and possibly 1 or more boosters, yet that booster was before September of 2022, the bivalent booster is recommended to ensure the most up-to-date protection. This includes children who received an all monovalent primary series before the bivalent doses were approved for their age group. For this group, the recommendation is not new, but it remains important and relevant given the additional protection that's offered by the bivalent booster. For many of the 1.7 million people in LA County who've already received the bivalent booster, their protections are up to date and they're not eligible for additional doses at this time. The exception to this is for 2 groups of people, those 65 and older and those who are immunocompromised and 6 years of age and older. For people 65 and older, a second bivalent dose administered a minimum of 4 months after the first bivalent dose is now an option for people who are seeking greater protections against COVID-19. If we look at the data for LA County, there's over 335,000 people in LA County who are now in this age group and eligible for a second bivalent booster if they choose. If a person is immunocompromised, we encourage them to speak with their healthcare provider. If appropriate, they can receive an additional bivalent booster a minimum of 2 months after their initial bivalent booster, and further additional boosters based on need. I know that sorting through this new guidance can seem complicated, especially the advisements for children 5 and younger. However, there's one simple way to think about it. Everyone 6 months and older should have at least 1 bivalent booster, whether it's their first COVID vaccine or their 5th, or 1 in a series for young children. And those who are 65 and older or immunocompromised now have the option to receive additional bivalent doses. I also want to note that the Biden administration announced earlier this week a program to ensure that the cost of vaccines continues to be covered. Acknowledging the importance of vaccines to minimize the negative impact of COVID-19, the Bridge Access Program for COVID-19 vaccines and treatments will be launched this fall to help make sure that there's broad access to COVID-19 vaccines and treatment for uninsured Americans. This program will work with pharmacies and local departments of public health to purchase and distribute free COVID-19 vaccines through these networks to those who are uninsured. Whether people are covered by health insurance policies or can participate in this new program, most people should continue to pay nothing out of pocket for COVID-19 vaccines. Next slide. As we think about the implications of the new vaccine guidance, it's worth noting how many people in LA County can take an action immediately to increase their protection from severe illness. In the youngest age group on this chart, children 5 to 17-year-olds, only about 15% of eligible individuals receive the bivalent booster. And this number is only slightly higher, 17%, for people who are between the ages of 18 and 49. For people ages 50 to 64, nearly 30% have had their bivalent booster. While this is higher than younger age groups, it's lower than we'd like to see. Just over 40% of people ages 65 and older have bivalent booster protection. This is especially concerning because we know this group is most vulnerable to severe illness. And based on the information we presented earlier, risk substantially increases without the bivalent booster. One big question that I know many people are asking is what will be the recommendation on getting a booster or a vaccine this fall? Both the FDA and the CDC will meet in June to review their information and hopefully issue guidance for the fall. However, their meetings this past week made it clear that folks who are not yet vaccinated with the bivalent booster do not have up-to-date protection. It is especially important that the nearly 750,000 people 65 and older who haven't yet received the bivalent booster in LA County take advantage of the additional protection offered by the bivalent booster and get this dose as soon as they can. Next slide. Our public health call center remains available to answer questions or help anyone that's trying to find a place to get the bivalent booster. And all of our public health sites, as of today, are offering the second dose for those who are eligible. The number to call is 1-833-540-0473. There's public health staff available to help 7 days a week from 8 in the morning till 8:30 at night. This is also the number to call if you're homebound and you want someone to come to your residence to vaccinate you. And it's the number to call if you've tested positive and you need free telehealth services. Vaccines and therapeutics remain free and easily accessible across the county, and the call center staff can help make sure everyone has access to the COVID resources they need. So please use and share this number, 1-833-540-0473. In closing, when we hear messages that the pandemic's over or that COVID-19 is now endemic, it gives the impression that people no longer need to be aware of its impact or take any steps to protect themselves and others. Just the fact that we're seeing new strains with possible different symptoms should remind us that COVID continues to evolve, and the way we think about our protections should reflect what we already know. If eligible, get the bivalent booster and make sure your protection is up to date. This minimizes your risk for infection, for long COVID, and for other possible side effects. The science and the data behind vaccine decisions is sound. So please continue to protect yourself and take steps to protect the people around you. With that, I'll open for questions.
Dr. Ferrer, we have our first question from Jackie Fortier at KPCC. She wanted clarification on the conjunctivitis. She was wondering, does the virus cause pink eye as a symptom, or is it because kids tend to rub their eyes and that's where they're getting infected with the virus?
Yeah, it's a really good question. We don't have any answers. I want to say that the information coming out of India is anecdotal. There's no peer-reviewed articles. We look back at the literature and there's very little mention of conjunctivitis in the past and very little detail, although it does note that 1 to 3% of people previously infected with COVID have in fact ended up with conjunctivitis. I don't know that we have enough information to say what that root of conjunctivitis infection was.
Thank you so much. I want to ask about the bivalent booster, and now really the bivalent vaccine.
The only booster.
Yeah, the only booster out there. So noting how low really it has been received, basically with 42%. I'm referring to most specifically for the age group that is the most vulnerable. What is the county doing in terms of efforts to boost that number?
Yeah, it's a great question because it's really important that people have good information and good access. So our mobile vaccine teams, about 4 weeks ago, started really prioritizing places where older residents may already be. Our senior centers, senior housing, assisted living. At our skilled nursing facilities, the rate is higher. It's about 68% of those residents have been vaccinated with the bivalent booster, but we've done an enormous outreach effort there that we'd like to replicate in some of the other sites where older people may live or work or go for, pleasurable activities. So we still, I think this week we had 700 mobile teams out, and the priority is to make sure those mobile teams are in places where older people would have easy access. And I want to emphasize, we will go to anybody's home to vaccinate them, because I think there's still confusion about that. It's 100% free. You just have to call us and we'll schedule a time, because we do know that some older people haven't yet received the bivalent booster because they haven't been able to easily get to a site. And we want to make sure everyone knows you don't need to come to us. We're happy to go to you.
Okay. And now let me ask you about the photo of you that went viral over Easter weekend when you were seen at a grocery store without a mask. Are you surprised by the level of attention that a photo of you maskless generates?
Well, I don't know if surprised is the word. I mean, again, I was there pretty early in the day. There were very few people. I felt comfortable. It was unfortunate I didn't have my mask. I usually do, but I didn't. At that moment, I didn't return to the car to find another one. And I felt very comfortable. It's a store that's actually very well ventilated, very big, and it wasn't crowded. I do understand, that people are anxious to figure out what they may want to do or not want to do. And as I've said before, the decision at this point to wear a face covering, a mask, particularly, a highly effective mask, is a personal one. There's no requirements except at healthcare facilities for healthcare workers that we wear our masks. And I'm like all of you. There are times where I do have my mask on because I feel like the risk is increased, and there are times where I don't because I feel like there's less risk.
Well, you are the public health director, and people look for you for guidance, and you do. That is your job, to give us guidance, the residents of LA County. Very few people there, very few people in the room today. So for the critics who say the mask hypocrisy, your response?
Yeah, I don't think it's mask hypocrisy. I mean, the guidance is exactly what I do. I mean, I always have followed our guidance. Where it's required that we wear masks, I wear masks. Where it's not required that I wear masks, sometimes I wear a mask depending on my risk assessment and what the level of transmission is in our communities, and other times I don't. I don't think there's anything hypocritical here. And I agree with you that, people pay more attention because I am the public health director. But I want to urge people that mask wearing at this point is a personal choice, except for a very small group of people who work in our healthcare facilities, and that we should respect that for everyone.
I have 3 questions from Ron Lynn at the LA Times. I'll go one by one.
Yes.
Question 1, do you expect a summer wave of COVID, or is that not clear yet?
I think there isn't clarity on when we might see another wave or if we're going to see another wave. I mean, again, mutating viruses that in other parts of the world are showing signs of being more easily transmitted is always something for us to pay attention to and to plan for. So it is possible that we could see increases in our cases sometime later this spring or in the summer, or maybe not at all until later in the fall, which is, a seasonal time when respiratory viruses tend to thrive.
Okay, question 2, are you seeing racial disparities in uptake of the updated booster?
We'll need to update our analysis on that. We definitely have seen pretty significant differences at the lower age ranges by race and ethnicity, and I would imagine that with a bivalent booster, that's continuing. I do want to note that that gap gets much narrower when we get to people who are older, where I think the message has been clearer and better. I think more people paying attention to it about the importance of getting vaccinated with the bivalent booster.
In some cases, the vaccines are working so well that some older people with mild COVID symptoms wonder if they should even take Paxlovid or Molnupiravir, even if they're prescribed the drugs. What would you say to them?
I always say, when you're prescribed the drug, it means that you've had an interaction with your healthcare provider and that you and your healthcare provider are in the best you have the best situation, the biggest advantages to deciding whether or not it's important to go ahead and be prescribed and take Paxlovid. I do want to say that Paxlovid has a really good track record at reducing severe illness, and the one thing you don't want to do is wait until you have severe illness before you take it if you're in a higher risk category. But again, since you're talking to your provider to get that prescription, it's important to raise any concerns you have with your provider.
We just got another question from Jackie Fortier at KPCC. Do we know how well the bivalent booster works against Arcturus?
Our assumption is that it will work equally well because this is, again, a strain of Omicron, the Omicron variant, but it's pretty early. We've had very few cases in the United States, so we'll have to rely on what we're seeing in India. They don't have the same access to the bivalent booster that we do here, so we might need to wait until there are either clinical or research studies and we have some evidence from the field. But our assumption, and I think it's a reasonable assumption, is that because it's an Omicron strain, we'll get some pretty decent protection.
Just for clarification, the bivalent vaccine and the bivalent booster are one of the same.
One and the same.
Same thing now.
Right.
So when we
Same
talk
thing.
about vaccines, it's just the bivalent vaccine.
Exactly.
Okay.
I think people are going to be a little bit confused because the word booster implies you've already been vaccinated. And again, this is the only vaccine that's available for people who have yet to be vaccinated. What you will get is the bivalent vaccine.
So then let me ask you the same question I asked you about the 65 and older. Given how low the vaccination rate is with the bivalent vaccine countywide, what will the county do to boost that rate?
Yeah, I mean, I think our efforts are to really go out to places where seniors already are located so that they have easier access. I mean, we also have our community health workers, our promotoras still out there answering questions. And as you know, we keep our call center open 7 days a week.
But beyond
yeah.
the older population, just everybody, because everybody needs to. That's what your message is today.
Our message is that it certainly provides protection to everybody. The group that is at highest risk of having a bad outcome should they get infected are people over 65 and people with some significant underlying health conditions. So that is where we're going to focus our efforts because that is where we're seeing most people who end up hospitalized and most people who tragically end up losing their life.
I don't think we have any more questions.
Great. Thank you, everyone.
Thanks, everyone.